Hi, I am MEENA from CHITRA TIRUNAL Institute, Trivandrum, working as a technical assistant. Today here I am going to present a topic on fetal MRI. To begin with, fetal magnetic resonance imaging is a non-invasive method which provides a detailed information about anatomical structures of a fetus. Ultrasound is the routine investigation for assessment of a fetal well-being. However, due to various factors like decreased amniotic fluid, fetal position, multiple gestation and reverberation artifact, it is very difficult. And also the subtle abnormalities can be very well demonstrated by MRI. Coming to the anatomy, usually the fetus in the womb is well packed by inside the uterus by amniotic fluid, and the main nutrition is by the placenta, which is connected through an umbilical cord of a fetus. Usually in the MRI of a fetus, we normally see the placenta, which is homogeneous, and spinal cord. Also anatomical regions like brain, lung, liver and heart. Coming to the safety of the obstetrical patient, it is very difficult for the pregnant patient for prolonged supine position. It is because gravid uterus of significant size can lead to hypotension due to compression of the inferior vena cava. This can be avoided by placing the patient in a lateral oblique or lateral decubitus position. In first trimester, the patient mainly come for the maternal indication and not for the prenatal diagnosis. Whereas in second and third trimester, after 20 weeks, the high level of acoustic noise generated in MRI system may be concern for both mother and the fetus. The common indications for the fetal MRI are CNS anomaly, equivocal at the ultrasound, evaluation of a complex fetal anomalies, gestational localization, intrauterine versus extrauterine, placental abnormalities, high-risk pregnancies, evaluation of gravid uterus, which is uterine leiomyoma, pelvimetry, evaluation of maternal extrauterine pelvic disease like cholelithiasis and pancreatitis. And the contraindications include like absolute and relative. The absolute are non-compatible pacemaker, neurostimulator, and cochlear implant, whereas relative contraindications are dentures, metal implants, and screws. Also, contrast in agent is contraindicated for the pregnant patient. Coming to the technique, MR exclusive screening of the patient is done and brief explanation about procedure is taken, given. High risk consent should be obtained and 4 hours fasting is required because it is to reduce bowel peristalsis artifact and prevent postprandial fetal motion. And also we ask the patient to empty the bladder. The positioning includes the position of the patient is in supine with a feet first orientation, and centering is done in iliac crest. The coil can be used as either phase direct coil or the body coil. The routine protocol includes 3-plane localizer and 3-plane haste, which is in axial, coronal and sagittal, and we go for axial diffusion and axial FL2D flash sequences. Here, haste is a backblood imaging, which is the workhorse for the fetal imaging for fine anatomical structure, whereas fiesta is a white blood gives an alternative way to look the fetal anatomy. These two sequences are resistant to maternal and fetal movement artifact, whereas the EPA is mainly for calcifications to see the blood products. Flash, it is used for evaluation of fetal structures with a high T1 signal, including thyroid, liver, and meconium. And hemorrhages is suspected when T1 weighted bright signal is seen this anatomical location. Coming to the MR imaging of a fetal brain, it is performed to detect abnormalities of the corpus callosum, posterior fossa structures, ventriculomegalae, congenital abnormalities of a brain, and ischemic hemorrhage. for the fetal planning, usually the localizer is done. After that, the fetal planning is done based on the corpus callosum of the fetus, and it is done parallel to the genome and splenum of the corpus callosum of the fetus. The normal brain. In contrast to the ultrasound, MRI facilitates cerebral biometry irrespective of the position of the fetal end. It is used as a biomarker of a fetal brain maturation. Example like normal sulcation and myelination. Here in this normal brain image, you can see there is a normal sulcate and normal myelination for the current age. Anencephaly. Anencephaly is a condition where there is a underdevelopment of the skull vault. In this image, you can see fetus with the absence of a cranial vault and herniation of the cerebral hemisphere. And here there is a choroid plexus hemorrhage. It can be zoomed in and seen now. There is a hypo bleeding in the choroid plexus. It is a gradient image and diffusion image showing the hemorrhage. And coming to the MR imaging of a fetal spine, it is mainly done to detect myelomeningocele, diastomatomalacia, spinal dysgenesis, bony spinal abnormality, congenital abnormalities of the spine, and Chiari 2 malformations. And for the fetal spine, first the fetal whole spine is taken for fetus, and after that the planning is done in the axial, like perpendicular to the cord, and after in sagittal it is done perpendicular to the disc and everything. This is how the normal spine looks. In the first anomaly scan, which is done in the 20 to 24th week, the spine development will be very well seen. If there is any abnormality in the ultrasound, they come for the fetal MRI. Here is the case of sacrococcygeal teratoma type 2, where the patient has a bulge in the sacrococcyx region. Teratoma type 2, it's a kind of a tumor. And here you can see the myelomeningocele. Also, it may be a myelomeningocele or a spina bifida. Here you can see the protrusion of a protrusion or herniation, very well seen in this region. And the MRI finding is suggesting of meningocele or spina bifida. Coming to the thorax, it is performed to detect congenital diaphragmatic hernia, pulmonary sequestration, congenital cystic adenoma and bronchial atresia. Here, congenital diaphragmatic hernia, sonographic diagnosis difficult because of the same echogenicity of a liver and lung, but it can be easily identified in the T1 weighted image on the MRI. For thorax, the planning is done. For axial, the planning is done in the coronal, and a sagittal, like a perpendicular to the thorax. And for a sagittal, it is done parallel to the thorax. For a normal thorax, normal fetal lungs exhibit a signal intensity that is slightly darker than the amniotic fluid. As the lungs mature, fluid fills the air space that are increasing in the surface area, and lung intensity increases. Bronchopulmonary malformation. Bronchopulmonary malformation is like a good predictor of the postnatal mortality, particularly in the pulmonary hypoplasia due to bilateral renal agenesis and pleural effusion. Here, congenital adenomatous malformation, it is involving in the right side of the lung, involving upper and the lower pole. And congenital diaphragmatic hernia is the condition like where fetal volumetric of a lung will be reduced as the as the bowel is herniated to the diaphragm region. Images show breach in the diaphragm with the thoracic herniation of the bowel loops. And coming to bronchial atresia. Bronchial atresia is there is a fluid collection in the bronchus, resulting in the lung obstruction. For MRI imaging of the fetal trunk, it is performed to mainly to detect esophageal atresia, duodenal atresia, small bowel atresia, anterior abdominal wall defects, omphoceal, hydronephrosis and megaureter, polycystic kidneys, and evaluation of the meconium. For the fetal trunk, axial planning is done on coronal and sagittal, perpendicular to the abdomen, whereas sagittal planning is done parallel to the abdomen. How does the normal trunk appears on T2 weighted sequences? The fetal kidneys are seen as ovoid structures with the intermediate signal. The presence of a T2 bright urine allows the visualization of the collection system. And fetal bowel, the eye signal meconium is seen mild to distal bowel in all fetus with a normal bowel on T1 weighted image in contrast to the surrounding structures. Coming to a small bowel obstruction, you can see a 3 bowel sign, which is also an indication of the small bowel obstruction, like a 3 bowel sign. Here the images show a triple bubble of a proximal bowel obstruction, suggestive of small bowel obstruction, and esophageal atresia. Here there is a narrowing of or fluid collection in the esophagus, which is seen as a bright signal intensity, and hydroerector nephrosis, where there is a fluid collection in the bilateral kidney. You can see the images here where the fetus has like a heavily fluid collected kidney. Coming to the advantages versus disadvantages, whereas ultrasound, it is a real-time display and it is a non-invasive. But fetal MRI, it has a superior spatial and soft tissue resolution, and ultrasound is operator dependent, whereas it is operator independent. Here small FOV and difficulty in obtaining multiplanar views, and here MRI large FOV is possible and multiplanar views is also possible. Here poor image quality in oligohydramnios and maternal obesity. Here fetal anatomy delineation and independent of the fetal position and the maternal obesity. Here disadvantages, reverbation artifacts, maternal bowel gas are the problem. Here poor visualization below 16 weeks gestation. And ultrasound is cost effective and is also less time consuming, whereas fetal MRI, it is expensive and time consuming, and also for difficult for claustrophobic patient. To conclude, birth and the survival of anomalous fetus depends upon its earlier detection and complete delineation of the type and extent of the anomaly. Ultrasound is a screening modality for detection of a fetal anatomy, but its characterization is possible only by fetal MRI. With the advent of newer techniques, fetal MRI is emerging an important imaging modality in obstetrics, not only in managing obstetrics, but also in non-obstetric complication. In conclusion, MRI imaging is a valuable complement to ultrasound when additional information is needed to make treatment decision during pregnancy. Thank you. I thank the ISRT and team for this wonderful opportunity to present.